Patient-Centered Primary Care Collaborative's webinar entitled Transforming Primary Care Through Payment Reform. My name is Marcy Nielsen. I'm the Chief Executive Officer here at the PCPCC. And it is my pleasure to introduce you in a moment to my friend Dr. Lisa Dulsky Watkins, who's going to be sharing with us her findings from a recently published report from the Milbank Memorial Fund. And that report is called Aligning Payers and Practices to Transform Primary Care, a report from the Multi-State Collaborative. As we will discuss in a minute, the Multi-State Collaborative is actually a voluntary group of state-based multi-payer primary care transformation initiatives that are themselves collaborations between a number of different stakeholders, payers, providers, employers, and state officials. And with support from the Milbank Memorial Fund, beginning in 2009, they have provided a forum for member states to share information, data, participate in collaborative learning, and advocate for improved collaboration between the states and the federal government as it pertains to primary care transformation and to health system transformation. So Lisa's report was based on a 2013 observational survey of the multi-state collaborative states, interviews with their leaders, and taking a look at the similarities and the differences in the activities of each state. So if you are one of those states, Lisa will be telling your story. If you are one of the states interested in learning about how to do this kind of collaboration, you are in for a treat today. I have just a few announcements before we begin. As many of you know, our annual conference begins on November 12th, and we've got online registration that ends on November 4th. You can still register on site, but the last day to actually register online is Tuesday, November 4th, and we've got lots of information in this month's newsletter that was just sent out this morning. So please go to our website at pcpcc.org/events. We are going to be, for the first time, having an awards dinner where we're going to honor the special contributions of 3 charismatic leaders who've been dedicated to primary care and to the PCMH movement, Deborah Ness, Dr. Ted Winslow, and the Southeast Texas Medical Associates represented by Dr. Larry Holly. So we hope you'll be able to join us both for the conference, but then this special celebration that will be the evening of November 12th. And then do want to let you know that we've got 2 new downloadable free slide decks relative to behavioral health integration into patient-centered medical homes. It's terrific information if you are interested in learning more about the topic or getting some resources that you can share with others. So please go and get those out of the resource section of our website. And then finally, before I introduce Lisa, as many of you know, the general housekeeping for our webinars is that we use webinar software to ask questions or provide comments. And in order to do this, we ask you to submit your questions in writing using the drop-down question box that's on your screen. Then during the last 15 minutes after our hosts have finished presenting, we will open it up for Q&A from the audience, and you can ask Lisa questions yourself, and we'll have an opportunity to have some of those questions answered, and feel free to make any comments. And then, as many of you also are aware, we do make the slides and this recorded presentation available on our website within the next 24 hours. So if you're not able to be with us in person, you can always go back and listen to our webinars at a time that is more convenient. So with that, it is now my great pleasure to introduce my friend, Lisa Dulsky Watkins. I'm just going to highlight a few key points from her illustrious bio, and you can find her full bio on our website, and we encourage you to go and visit her bio as well as other information about the terrific work that she's done in the state of Vermont. She is the former Associate Director of the Vermont Blueprint for Health at the Department of Vermont Health Access. This is one of the founding members of the Milbank Memorial Fund supported multi-state collaborative, so Lisa has firsthand experience in writing her report, given all of her work in Vermont. She served there from 2008 to 2013, also as the Chief of Operations, where she managed a lot of money, a multi-million-dollar budget, and was the liaison to Vermont's health system community. So other physicians, medical providers, hospitals, allied health professionals, etc. Prior to that, she was a researcher at the Vermont Program for Quality in Healthcare and a medical content reviewer at Problem Knowledge Couplers Corporation. She serves on a number of different committees and advisory groups, to include being a cabinet member here at the PCPCC's Advocacy and Public Policy Center, as well as the Patient-Centered Medical Home Advisory Committee for NCQA, and the Best Practices Innovation Collaborative of the Roundtable on Value and Science-Driven Healthcare at the Institute of Medicine. She is a former pediatrician in Vermont. She is often asked to be a guest lecturer, panelist. She's also really fun to have cocktails with. So with that, I am going to turn this over to Lisa and thank her again for joining us this afternoon.
Thank you so much, Marcy, and thanks to the PCPCC for this opportunity to really share our findings of the report that was what we find really important in terms of looking at primary care transformation moving ahead. So this is just a little screenshot of the report cover, essentially, that was published this April at by the Milbank Memorial Fund. As Marcy said, this report was based on an observational study done last year, including a survey that was structured, questions that were responded to by most of the states in our collaborative, as well as interviews, which were questions that were the same asked of each of the individuals, but not done in a rigorous manner. So it's truly an observational study. So the agenda for today's talk, I'm going to give you a little bit of an introduction to the Milbank Memorial Fund, which has been generously supporting this work over the years. I'd like to describe the multi-state collaborative, which is, as I said, supported by the fund, and is a group of volunteers from around the country in doing this type of multi-payer primary care transformative work. I'm going to share the shared guiding principles of multi-payer transformation that we were able to identify in the report and through our study, the central components of the programs, and we're really trying to pull together the things that these programs share. They have more in common than they do in contrast. I'm going to share with you the lessons learned in the early years, and then really to introduce the idea of what the implications may be for future policy setting. And I very much welcome your ideas in our question and answer session to hear what you think about this. The Milbank Memorial Fund is an endowed operating foundation that has worked to improve the health of populations by connecting leaders and decision makers with the best available evidence and experience. The fund is over 100 years old and has been at this type of activity for many years. It is truly a nonpartisan organization and engages, therefore, in nonpartisan analysis of significant issues in health policy, bringing together leaders from around the country to share ideas and educate the general public as well as the people involved in policy making. The multi-state collaborative was in 2009, the fund has provided support to state leaders committed to transforming primary care. And the member states had been working independently on multi-payer initiatives and sought to share their experiences and outcomes with each other. In 2010, the group took the name the Multi-State Collaborative, really coalescing into an organized group. My point today is that the evidence on the value of high-quality primary care is indeed strong, and the projects underway in the states are starting to generate positive results. I'll be sharing some information with you that is outside of the purview of the published report, but I wanted to really make the point that the collaborative is an organic and growing and evolving entity, and that the report is a specific point in time, but things have obviously continued to change. This report documents the evidence of the, excuse me, the efforts of these collaboratives. So this little schematic map of the United States, I've highlighted the states that are involved in the collaborative thus far. At the point that the study was done, we did not have as many states as we do now. We've had some significant expansion in the last calendar year. But I just want to show to you that the states are around the country. We do have increasing geographic representation, although we were originally very much focused in the northern New England area. So some of our states are involved in federal demonstrations with the Centers for Medicare and Medicaid, and are working in multi-payer settings where they actually have both the public and the private payers involved. Some of our states do not yet have Medicare involvement, but have working in multi-payer. And I'm going to explain some of the demonstrations to you. The multi-payer advanced primary care practice demonstration was the first demonstration that was now handled by what is the Center for Innovation. I'm sorry. This started in July of 2011, and CMS entered into, Medicare specifically entered into demonstrations that were already ongoing. So as I mentioned, the states that were involved in the collaborative initially were those that had already sort of began this process of working in the multi-payer space. And Medicare joined 8 states in their already ongoing activities in multi-payer work for transformation of primary care. As I said, it started in 2011. The original termination date for the demonstration was December of this year. That will be, in fact, terminating for 2 of the states, but in 6 of the states, an extension was just granted for another 2 years in order to complete the demonstration evaluation fully and allow the impacts to be demonstrated. The authority for this particular demonstration falls outside of the Affordable Care Act. It was before the ACA was passed, and it's from Section 402 of Social Security Amendments of 1967. The Comprehensive Primary Care Initiative is a newer demonstration, also very much focused on multi-payer activities, offering enhanced support to practices and to benefit patients, as the MAPCP demonstration has already done. This program has started later, so it has a termination date that's a little bit later in 2016. It is different from the MAPCP in some very important ways, probably most notably that it has a very consistent structure and milestones. So as opposed to Medicare joining in already existing programs and therefore having to adapt in 8 different states to different programs, this was a much more a preset set of targets and much more structure to it. And as I said, that the authority for this is through the Affordable Care Act. So I'd like to share with you the guiding principles that we were able to pull out of our study. The first is that multiple insurers, and ideally all insurers in a given state or market, must pay for services the same way. This is the only way to stabilize and ultimately bring down healthcare costs and make it more manageable for the practices that are implementing the changes. Second is that both primary care and related supporting services are essential building blocks of delivery system transformation. I think that there's been ongoing struggle for primary care practices for many, many years with trying to deliver services that are outside of the purview of the medical interaction. So a lot of work with social services, related things like nutritional services, behavioral health services that are not necessarily delivered adequately or comfortably in the primary care setting. So it's very clear that primary care and related services thrive with each other, but not without. High-quality primary care is more likely to occur in a consistently supported and formally recognized patient-centered medical home setting. So the move towards recognition nationally or locally or statewide as a patient-centered medical home, which has the implication, of course, that the care delivered in that practice is of high quality, is very important, and having specific targets that are met and then renewed is essential. The multi-payer model alone is not enough to create and sustain the transformation. The programs have to establish non-traditional working relationships. And what we observed is that within practices, through team-based care, relationships can be altered so that the practice really works more smoothly and functions at a higher level. And then there really is a necessity to have collaborative learning. How do we learn from each other's experiences? How do we share our own experiences? In settings where practices or organizations are competing for market share, how do you transcend that and actually share collaboratively the information and experience? This is the logic model that we used, and it really just summarizes what I've just shared with you, that on the left you have multi-payer payment reform, collaborative learning, team-based care. All of these are components that will move the practice in a transition. And you can create then a patient-centered medical home and recognize it as such, and then support it with enhanced funding and services as necessary. Assuming that that delivery system change takes place, then the following sequelae will happen, with, hopefully, which is that you have increasing quality of primary care based on the patient and family needs, with an aim of improving population health, as well as containing healthcare costs and ultimately increasing affordability. So the essential components of the program. What I've done here is I've pulled out 8 essential components, and I'm going to give some illustrations for them. So really taking things out of the report that you are welcome to read, obviously, if you've had a chance to look at it. And in addition, I've added some information that our member states have shared with us. So the first component is that innovative payment reforms designed to support primary care must be developed and implemented. An example of that comes from Vermont and their community health team funding. Each participating insurer will contribute to the multidisciplinary community health teams, and their financial support of these teams, which are multidisciplinary, locally based care coordination teams, their participation is mandated in state statute, which is an unusual situation, obviously, but it has made for a tremendously successful and very solid infrastructure to support primary care. In the case of Vermont, these payments are made to a local coordinating entity, and access to the staff and services of the community health team are completely free to any patient who is attributed to the practices that are served by the team. So the insurance status of the patient, whether or not that patient has a pre-existing eligibility issue, any sort of chronic disease, all of those things are important but not relevant to whether a patient has access to the service. It is free to the patient. Multiple payer participation is completely essential. This can be a very delicate negotiation as if you are in a situation where you don't have a state mandate to compel everybody to participate. And we have been very impressed by the very successful local activity of many of our partner states, where they have had to work very closely with colleagues in industry, specifically in the payer community, and really get them on board to do something voluntarily. And to our colleagues' credit in the insurer industry, there's been a huge amount of willingness to participate, and also to, in some cases, really start a lot of the process, to be the spark that allows this work to move forward. In the case of Colorado, which had a 3-year patient-centered medical home pilot, although now Colorado is part of one of CMS's demonstrations, the Comprehensive Primary Care Initiative, payment mechanisms included fee-for-service, care management fees, which are done on a capitated basis of per member per month, and pay-for-performance mechanisms. And in the case of this particular pilot, 7 health plans voluntarily participated. state government has a very essential lead role. An example of this is in Rhode Island, the Office of the Health Insurance Commissioner and the Rhode Island Department of Health really pushed forward the agenda through, not through legislation, but through regulation, and created effective collaborations that led to successful programs being implemented since 2008. So they have a very strong patient-centered medical home program, as well as Rhode Island was the recipient of a Beacon Community Grant with a great deal of emphasis on health information technology to benefit the primary care practices as well as other parts of medicine in the state. I'd like to give an example of one of our newer states. Rhode Island has been at this for some time, as you saw, since 2008, and is part of the multi-payer advanced primary care practice demonstration. We recently were joined by Montana in our collaborative, and I think that this is a great example of states learning from one another. They designated their Commissioner of Securities and Exchange as the convener of their new patient-centered medical home initiative. And so with the support of that part of state government and the administration, they have a developing and really increasingly successful patient-centered medical home program underway. Consistent standards for patient-centered medical home identification and recognition need to be in place. The majority of the states involved in the multi-state collaborative are using the National Committee for Quality Assurance standards as recognition for their practices, and over the years, the versions have gotten more rigorous in terms of the requirements for recognition. I'd like to point out that some of our member states have designed and then subsequently updated their own standards for recognition as a transformed primary care practice. So there are multiple ways to do this. As I mentioned before, new staffing models for team-based primary care are very important, and the traditional hierarchy of the physician being the leader in basically setting the rules and the tone is something that can work in certain circumstances, but team-based care with a more open approach to different disciplines taking on responsibility seems to be very important. A good example of this is in Maine, where they have community health teams similar to Vermont. And in their case, each team is supervised by a social worker. The staffing of the teams is a combination of nursing and social work staff, as well as central scheduling and administrative support. And in Maine, they've taken a very active interest in using trainees as important team members. So they have social work interns, pharmacy and medical residents, and students of nursing and medicine, all part of the team and contributing. I think this is an important point in terms of the workforce issue that we are facing nationally. We need to be open to using multiple disciplines and trying to figure out how to solve the crisis in primary care workforce that we are confronted with looking into the future. Technical assistance to practice sites and really helping them reach a new bar in terms of the quality of care they deliver is essential. Almost all the states that we surveyed use practice facilitation as a mechanism of working with the practices to improve their capacity. Practice facilitation has been described very in great detail in an ARC publication from 2011, as well as through a lot of work that's gone from the Mary Naylor and the work from the University of Pennsylvania. But the definition to say that it provides a range of organizational development, project management, and quality improvement methods helps to build the internal capacity of a practice. It's an incredibly important and very resource-consuming activity. These are people that go into the practice and work one-on-one with staff members to help them improve their workflow and use of information technology, use of data to improve the quality of care. Another essential component, which I'm sure comes as no surprise, is the common measurement of performance at regular and frequent intervals needs to be transparent and trustworthy. An example of this really having evolved over time is when you look at the CMS comprehensive primary care initiative has really provided a uniformly applied set of metrics which allows to assess the practices transition to advanced primary care. And we think that the experience of the MAPCP programs help to inform that development. And the next two slides are very busy and dense, and we don't need to spend much time on them, but it's nice to see the sort of a summary, essentially, of the practice milestones that the practices had to meet in the year one of their activity in the Comprehensive Primary Care Initiative. And then there are specific clinical measures that they needed to use in order to show that they're providing high-quality care. So having this be consistent, having all the practices use the same metrics is very important because it allows for a much broader evaluation and being able to compare practices and areas to each other. Collaborative learning is extremely important. One example I just wanted to share is that when you look at Michigan's primary care transformation program, the MyPICT, they serve over 1 million patients, and they really have made shared learning a priority. They have just dozens of ongoing and topical learning opportunities scheduled every month, and they really reach out to all the different disciplines that are involved in their program, as well as the very active engagement of patients as advisors, as well as reaching out to families. The next two slides are outcomes that are related to these essential components. This is not information that's actually directly in the report, but we're at the point where we would like to start to extrapolate from the early experience and trying to loop in the newer information that we have. Innovative payment reforms designed to support primary care have been a huge focus in the Vermont Blueprint for Health. And it's taken 5 years of collecting data and analyzing it to be able to demonstrate the efficacy of the program. Vermont does have an all-payer claims database, and there's excellent analytic work going on in the state with, as you can see here, you can actually compare the blueprint practices that are involved in the actual transformation, and then comparing them to practices where they've been matched. And you can see a difference of total expenditures per capita that is increasing in size. It's taken a long time to get to the point where you have enough experience to do that, and so it's important to keep in mind that it does take years to be able to demonstrate that. In the Colorado pilot that I had mentioned that had been in place, they had multiple public and private payer participation. This was published in Health Affairs in 2012, and they did see an overall cost reduction as well as utilization reduction. In Maine, they've been able to demonstrate emergency room utilization dropping with the onset of the community health team, or community care teams as they call them in Maine. Once again, this is an indication of staffing models and putting a team in place that allows for some care coordination that otherwise would not have been there. With emergency room visits being one of the more expensive parts of the healthcare dollar being used, as an important component. And then this last slide, also quite busy, my apologies, but I wanted to just give you a sense of what's going on in Michigan when they talk about their collaborative learning. They really mean it. This is just from their monthly newsletter. There are too many words to even fit on the slide, and they have multiple learning opportunities with webinars, regional meetings that happen several times a year, and they have roadshows, as they call them, where they go out and do the faculty moves around the state to share that information and techniques that can be used for primary care practice transformation. So the lessons learned. The logic of the multi-payer effort to support primary care transformation, we believe, is irrefutable. State leadership at the highest level possible is necessary for the success of multi-payer primary care transformation. And a multi-payer approach is key to engaging both clinicians and payers in the process. Reliable data and measurement are essential to success, yet remain a challenge for many of the states. All, probably. The transparent sharing of experience and information can lead to effective learning, especially in the collaborative setting. And these collaboratives are improving outcomes for populations in significant and sustainable ways with varying levels of success. There are differences between the states. The business case for primary care transformation must be clear, and we must be able to persuade policymakers, purchasers, and patients to expand. And we believe that the findings of this report have implications for future payment reform. And I'd like to expand on that last point a little bit with implications for future policy. So in Vermont, and this is not unique to Vermont, in all states now, there are development of accountable care organizations and other what might be referred to as larger or more comprehensive payment reform efforts and initiatives. In Vermont alone, there are 3 different accountable care organizations, and the question immediately comes up of, well, we're going to put this accountable care organization into place, and we'll need to address the questions of care coordination, care management. How do we build that into our ACO so that we can, try to enhance the possibility of there being some sort of savings that can be shared. And it's been very interesting to see the process because it really has required a great deal of communication, collaboration, and really trying to work together to not undermine the existing infrastructure that's already been put in place for primary care support, but instead to incorporate that into the larger payment reforms as they develop. So in Vermont, there's really been a tremendous effort, and I think moving very well and successfully to try to align the goals of the 3 different accountable care organizations, use the same quality metrics, use the same health information system, have a single clinical advisory board, and really coordinate the protocols so that they are the same and actually implemented the same way. The future is still not totally known yet, obviously, but it's required a great deal of coordination, collaboration, and I think the experience of having been in a successful multi-state collaborative can certainly help and support the states as they move forward. So this is just, I'm happy to entertain questions now. Obviously, the resources here are the report itself. I'd encourage you to visit the Milbank Memorial Fund website. There's a huge amount of wonderful information there. And I can be reached directly if you need to ask me questions offline.
Thank you, Lisa, for that fantastic overview. So we're going to open it up now for Q&A from the audience. As a reminder, if you would like to ask questions or provide any comments, just type them into the drop-down question box on your screen, and I will present them to Lisa. So we have one question already on, the topic is on Rhode Island, and this individual is asking, what is preventing states from doing what Rhode Island did, which was mandating the 10% spend on primary care by insurers? Or are there states that are considering this, and if so, what are some of the barriers?
So that's a great question, and I think that the political environment in each state is different, obviously, and the forces that having the it's not even the strength, it's really sort of the positioning to be able to enforce that kind of a regulation is one that is a little bit hard won depending on the circumstances. So there's nothing really stopping that from happening other than there's a lot of upheaval around other types of reforms. So I would say if the wherewithal is there and the political environment is right, it can happen. I think there probably one of the important things is to have a groundswell of support from the professional societies, from the practices, from consumer groups and advocates, because I think sometimes decisions are made at the policy levels that don't necessarily have all those factors taken into consideration fully. So the grassroots local advocacy can really have a huge impact.
Great. So the second question is on Vermont, and this individual is asking whether the Vermont data on expenditures is inclusive of payer, state, or federal funds spent on medical homes or EHR initiatives.
So the data that you saw was the claims data. So that's that's all the claims that are, and obviously that is. It's been a while. It took a while to get all of the payers into the all-payer claims database. So the modeling that was done actually did take into account the investment that the state has made, but the revenue and the claims that you're looking at do not include the enhanced payment to the practices or the cost of the community health team. That data is really just from the claims.
So speaking of the claims data, are there any other population health tools that different groups or states used other than the statewide claims databases?
I'm sorry, can you repeat the question?
Sure. So other than statewide claims databases, are there any other population health tools that the different groups are using?
I think that all of the states are looking at a multitude of different types of evaluation tools. So many states are using surveys of patients and of providers to determine if the experience of both receiving and delivering care has changed as a result of the patient-centered medical home initiative. And that, obviously there are limitations to any sort of survey that you do, whether it's telephonic or, electronic or mailing something to someone's home. But there has been a very impressive change in pretty much every state that's done this work, where they're looking at increased and improved experience of receiving care by patients. And I think the primary care physicians also have been very happy with certainly the community health teams and having this sort of support from a multidisciplinary team for things that they really felt that they were having trouble doing themselves, such as providing mental health services and coordination of care. The states that are also involved in this, in addition to looking at claims, they look at other aspects of the cost of the investments, as I mentioned. So for an example would be in Vermont, where the state has actually put in money from the general fund, really through Medicaid, to kickstart a lot of this work and to maintain a budget. That is also part of the evaluation that the state does itself.
Great. So talking more about the teams, this question is asking how might pharma-supported CME or CE help physicians and nurses learn and transform their practices?
I'm sorry, Tara, do you mind repeating that question?
Sure. So this one is asking specifically at pharma-supported CME.
Pharma-supported? Is that what you said, pharma?
Yeah, pharmacy-supported. How can they help physicians and nurses learn and transform their practices?
I can't answer that question.
Okay.
I'm sorry.
Okay, so the next question is asking what approaches are used to pay for the community teams to tap on payers in any other ways. Are there direct services for public health departments, for example?
So the community health teams, and they are in various formats in different states, but generally there are teams that are paid for by the participating insurers through some sort of a fee, whether that's directly to the team or they're actually paying the primary care practice to hire members of a team. It can vary depending on the mechanism that's used. And those members then are called upon by the practices. Typically, the provider will request certain services for a patient, but in some cases, the patients can self-refer.
Can you describe a little bit more about how the community-based teams are managed and paid for?
Sure. So in Vermont specifically, the community health teams are managed at the local level. So the state of Vermont is very small. It only has about 600,000 people, and it's divided into 14 health service areas. In each of those service areas, there's generally a community hospital, and typically it's the hospital that is the managing, or someone at the hospital managing the care coordination team, although it's not always that. It can be a federally qualified health center, for example, can also take on that fiduciary responsibility. They actually have this wonderful, messy, democratic process that's ongoing with a health services community-wide group with multiple stakeholders. People come together, and they have to decide, based on the needs that they can identify in the local community, what would be the best use of those new resources. What kind of person should we hire? What type of disciplines would be most useful? It's pretty consistent in terms of there being identified need for mental health and substance abuse services. There's often identified needs for care coordination, other type of social service links. There's also need for nutritional services, and often links to transportation and other things that really contribute to whether a patient can access care appropriately. The management of those teams is at the local level. So the state doesn't hire them. The insurance companies don't hire them. It's actually they're hired by this local entity, and those teams are managed at that level. And they do vary a little bit. I mean, certainly even within Vermont, there are some demographic differences between different areas of the state. We have, one densely populated area in the Burlington area. The rest of the state is really quite rural, and the needs are a little bit different as a result.
In looking at patient surveys, what response rate did you get on these surveys?
Well, the patient surveys, is that the question? So that
Correct.
would be highly variable. The CAP surveys, which is one of the more likely to happen, I think they were looking at maybe a 25 or 30% return rate on the survey. In some cases, less than 20%. It depended. For the children, it was in pediatric population, it was less than 20%. But that really varies state to state and community to community.
Can you talk more about what % of the commercial insured market took place in the initiative?
That also varied state to state. In Vermont, it was because of the mandate, the major commercial payers, which are the three commercial payers, were all in. I think that the question maybe underlying that is what percentage of the self-insured market participates in this, and that is highly variable. Some major employers are very willing and engaged in this, certainly IBM, the state employees in Vermont. I mean, there are many employers that are very interested in participating in this kind of thing, but they are not compelled to because of ERISA. So we have variable participation.
So I know this will vary by state and initiative, but since the payments included per member per month and pay for performance, do you know what the ranges were for those arrangements and the % share on pay for performance? So
I don't have the details about the pay for performance, and I guess I need to make clear that this study was looking at 10 different states which had widely variable implementation of multi-payer activity. So the pay for performance was not present in a number of the states and was in others. And the per member per month payments that were part of for example, the MAPCP demonstration ranged from maybe $2 to $8 per member per month. And that was covered by Medicare, Medicaid, and the commercial payers that were involved. That's in contrast to the Comprehensive Primary Care Initiative, which pays a higher per member per month payment. But it's, as I said, it's a different demonstration. And this report really reflects the early years, as I said, only the first couple of years of the multi-payer work as we started to observe it.
So from your perspective, Lisa, how could the care team function work when the state acts as a payer in employees' managed care organizations? I'm sorry, let me repeat that. How could the care team function?
Yeah, I'm looking at the question. So how could the care team function work when the state as a payer
employs managed care organizations?
I think that that's one of the big questions, and my personal belief is that the managed care organizations need to be responsive to the environment in which they are working. And so in a local environment where you already have an established infrastructure that is clearly working, there has to be a way to either contract or somehow bring in the work that's already happening and accept that that's good work and it needs to continue. So a managed care organization doesn't have to clear the slate and start anew. I think there's really a role for incorporating existing successful programs and staff. But that takes a new paradigm in terms of perhaps a new financial arrangement. I think there are lots of questions about that, and I don't pretend to have the answer to that yet. I think that's really being worked on very hard all over the country.
So with regard to Vermont's model in developing regional teams, what collaboration occurred with existing providers and care organizations, and what roles do they have now?
So at the local level, the care organizations, and I would refer to that as that's a pretty wide. I don't know how that's being defined by the person who's asking the question, but I would describe this as a true partnership where there's a pot of money and a decision is made by people who will be using the services and delivering the services at the local level. So an example would be for mental health services that had been traditionally or previously delivered through a community mental health center as well as through private providers, psychiatrists or psychologists. Allowing for the salary of I would say, a full-time equivalent person to serve on that team would allow for, let's say, some very brief interventions, brief treatments, things that really could be handled in the primary care setting, and then more appropriate referrals out to the organizations that have more capacity to handle more seriously mentally ill people or longer-term treatments. So I think there's a reshuffling of some of the types of treatments that are done or needed so that people have the opportunity to really work do what they do best and to do a better job triaging and not have people enter into a system that they don't necessarily need long-term treatment or in a specialized facility. So it's really kind of stepping back and evaluating what are the services that are actually needed, how do we fill the gaps that exist, and how do we make sure that the people who provide good care get appropriate referrals and continue to be able to do their work.
So, Lisa, I think we just have one last question, and this one is asking if you can point them to a source as to a comprehensive comprehensive list of recommended or commonly used PCMH cost and quality measures.
So I think that the Center for CMS certainly has done a huge amount of work on the Comprehensive Primary Care Initiative, which speaks directly to the patient-centered medical home and advanced primary care. And they're in the process of putting some of this information in the public domain. It's still in process, but that will really be a definitive source. I think I think that would actually be a really great task for Milbank to be able to collate that. The other place that I would look is the National Academy for State Health Policy has an excellent and very detailed patient-centered medical home page and sections of pages where they look at all the programs nationally, and I've started to do some work on how the metrics are collected. So I would refer you to that as well.
And I would also refer everyone to PCPCC's map, which does list out all the various outcomes data, and you can filter. We actually have built in an outcomes view that allows people to search and filter data, whether it's cost, utilization, population health, improved health outcomes, etc.
Absolutely. The PCPCC's map is relatively new and very, very thorough. It's a wonderful tool.
So Lisa, I think you have done a fantastic job of answering all the questions. We had quite a few, but I believe we got through everything.
Great. Well, thank you very much for this opportunity, and I really look forward to future collaborations. Thank you.
Thank you, Lisa, and thank you everyone for participating in today's webinar. As a reminder, the slides and the recorded presentation will be posted on PCPCC's website within the next 24 hours. So once available, you can access them at www.pcpcc.org/webinars. Have a great rest of your day. Thank you.